introduce themselves. Perhaps what I'll do is I will call people out to ask them so we're not all confused by what order to go in. I will say this meeting is recorded. You have the right not to be recorded, which I think essentially means not being on the meeting. Dr. Jett, if you could introduce yourself first.
You're on mute.
You're on mute.
Yes, Dr. Swanee Jett, Health Commissioner, Brookline Public Health.
Okay. Now I'm going to ask the members of the council to introduce themselves. Dr. Stoddard.
Hi, I'm Gretchen Stoddard. I've been on the advisory council for a little over 4 years. Thanks.
All right. Dr. Hemingway.
I'm talking.
Hi, I'm David Hemingway. I've been on the advisory council for almost 1 year, and I'm from the Harvard School of Public Health.
This is probably, I hate titles. Pat, you should be a doctor too, but I don't think I can introduce you as that, but please introduce yourself.
Hi, I'm Pat Marr, a very proud nurse practitioner, and I have been on the committee almost 12 years.
Okay. Dr. Moyer.
My name is Peter Moyer. I'm a retired emergency physician, and I'm a 2-year veteran.
All right. And Darlene, you want to introduce yourself?
I am Darlene Johnson, and I am the administrative manager of the health department.
Dave, can I turn it over to you to introduce yourself and call out the members of your committee?
Be happy to. Thanks, Tony. Dave Gayshock, a town meeting member from Precinct 13 and a Brookline school parent and co-chair right now the school's advisory council number 4, or sorry, advisory panel number 4 on public health, safety, and operations related to return to school amid the COVID-19 pandemic. And I co-chair that with Dr. Elena Savoya. Dr. Savoya, do you want to introduce yourself?
Hello, everyone. I have the honor to co-chair the panel with Dave. And in my real life, I'm the Deputy Director of the Preparedness Program at the Harvard School of Public Health. And I've been co-chairing the panel for the past 2 months, so my real life doesn't exist anymore, essentially.
And Dr. Summers?
I'm Ben Summers. I'm a professor at the Harvard School of Public Health in David's department, and I'm also a primary care physician and professor of medicine at Harvard Med School.
And Dr. Pollack?
Hi, I am one of the directors of the Clinical Microbiology Lab at Boston Children's Hospital and a member of the Infectious Diseases Division at Beth Israel and a Lawrence parent.
Okay. So this is panel 4, the Public Health Advisory Panel 2, the school committees asked for a chance to present to us and discuss with us. And our main agenda item today is indeed the school reopening plan. We have 2 other agenda items. One is an update from Dr. Jett on COVID in Massachusetts and in Brookline. And then we have some minutes to take care of. But I thought, since it's usually a relatively brief agenda item and having the setting for what is happening as of today in Massachusetts and Brookline is an important starting point to talk about school opening. We could do that first. I think everyone should be interested in that. So Dr. Jett, can we have you do that first?
Yeah, sounds great to me.
Okay, the floor is yours.
Hey, Darlene, do we have, okay, thank you. Let's see, I have my screen. Let's see, share the screen. Let's see. All right, this is just a update briefing that I provided actually to town employees this morning. Gives you just the overview of where we at in cases today. So as of today, we have 432 positive cases and probable cases. We have 118. These are the people that have had an antigen test to show that they actually do have COVID, but they never get into the positive category. And we have 59 deaths, which mainly from, our nursing homes. Care One takes up the majority of these deaths. This is our cases over time. As you can see, we peaked pretty much at the time that the mask mandate went in Brookline. And the only other time we had any type of rise actually was in July, right around the 21st. So these are the cases of COVID to date. The highest rising group, which is different from previous months, is the age 20 to 29. When we started this, we had very few kids in the 0 to 9 and 10 to 19 category. Now, as you can see, 10 to 19 is over 10%, and 0 to 9 is slightly over 8%. And so these three categories are the ones that have been rising, as whereas in early in the COVID, 50 to 59 was the highest, and then it was 70 to 79 and 80 to 89. So we're starting to see a shift.
These are numbers, not percentages, all right?
These are percentages.
Yeah.
Yeah, these are percentages. Well, I guess you could say number of cases. I take that back. Number of cases.
Yeah. Okay.
So I know you can see this. This is the number of cases reported by race. We still have a few unknown, and that's because, early in COVID, we didn't get a lot of data that was reported from the nursing homes. And so we couldn't interview those individuals. But this is this hasn't changed significantly since the outbreak has started. This is the range of deaths, and this is a new chart where you can see the number of deaths and the age category of deaths. So, I wouldn't say much has changed. We haven't had any deaths younger than 60 at this point, unless something hasn't been reported to us, which is very possible. We do have a few deaths that wasn't reported here, but when I looked at the death certificates, it was of COVID nature in early February, which could have gave us a clue as to what was going on. And that's pretty much it. So anybody has any questions?
We've never looked at the observed to expected, say in January through March, to get a sense of how many cases we might have been having when nobody was thinking we had COVID.
Originally, I think it was back when we first started. If, I wouldn't say I ran a simulated model, but if we hadn't reacted as fast as we did with increasing our EPI staff, which, shutting down the health department and turning environmentalists to EPIs was key, because we immediately had, 8, 9 people on ground. And then, when the school shut down, I think 3 or 4 nurses eventually helped out, which that was big. But I had originally anticipated in the first 30 days, I expected 1,000 cases. And I talked to Dr. Monica Burrell, and her interpretation at the time is she thought that Brookline would get no more than about 90 cases. And I was like, yeah, I don't see that happening. I think we'll reach that number by the time this is over. We'll reach 900. Since we had 5 something now, I can easily see that going into the fall months. And of course, we lost a lot of people in the beginning, which is the reason we have suspected and probable categories, is because there was no testing, and a lot of doctors' offices just telling people with mild cases to stay home. And so we drastically probably underreported our numbers at this point.
Right. Okay. If there are no other questions, we'll move on to talking about the school openings and turn it over to our guests. So, Mr. Siosko, please.
Excellent. So I will introduce the team here, and just to explain a little bit who we are. We are parents, first of all, and we are all volunteers. We were invited by the school committee to volunteer, and simply there was a call from the school committee that went to all parents asking if there was any expertise in public health. And all of a sudden, they got a lot of good people answering. And at the moment, we have a group that has experience in different areas, including emergency preparedness, infectious diseases, diagnostic testing, pulmonary disease, intensive care unit, pediatrics. So I think it's a very nice range of areas and expertise. And I think it's very important that we talk today to each other, because definitely one of the main issues in preparedness and lesson that we never learn is lack of coordination and lack of consistency in communication. So we really would like to see coordination and consistency in the type of messages that come out to our community, and probably talking to each other and making sure that there is this exchange of information and knowledge between groups. We believe it's very important. I think that probably the most challenging issue that we have faced so far across all topics that we have addressed is the fact that it's quite difficult to explain to the community that there is not one single metric or one single preventive measure that will solve the problem and that will get us prepared. But it's a combination of measures, and not all the measures are perfect, and they don't necessarily have to be all perfect in order to reopen the schools. I will pass it now to Ben, and then each of us will give like a 2 minutes overview on the evidence, on the metrics, on testing, and on issues about clean air ventilations. And these are the main topics that we have been working on so far. Thank you for having us.
Great. So I'm going to describe the evidence review that a subgroup of our committee, which includes an infectious disease epidemiologist, a nurse with expertise in occupational health, and then primary care and health policy, that we've been essentially updating in real time. We continue to do, and I think we've shared that document with you, but we'll continue to send it as new results come in. So there are tons of studies in this report, and dozens more that we've reviewed and haven't necessarily called out individually. But the big picture findings that we think are critical, the first is the nearly universal finding that rates of serious illness by age are lowest among children, in particular school age. And when you look at children who have serious complications, they tend to most likely be in neonates. And by the time you hit 3 or 4, those rates fall pretty dramatically. And you could see that in the Brookline numbers as well. But that's probably not the kind of critical question for reopening schools. The question is asymptomatic carrying, transmission among schools, what happens when you bring children together? So Tony, in part based on your very helpful framing in your email, a couple of the studies that are most relevant here, there's a New England Journal of Medicine study that looks at population-based screening in Iceland, where they took a random sample of the population regardless of symptoms and tested for the prevalence of infection. A similar study done in Italy in a high incidence town there at the outset of a shutdown. And then serology testing looking at antibodies regardless of the presence of symptoms. And in these studies, what they find consistently is that generally, the children are significantly lower risk of having been infected in the first place. Lowest rates among the 0 to 10 age range, but also lower in the 10 to 20 range in most of these studies. And critically, again, these are kind of all comers. So this includes people who are asymptomatic. And in the 2 studies I mentioned in Italy and in Iceland, these were conducted when schools had been open. So this is not an artifact of children being at home because schools were closed. Case tracing that has been done and also in multiple peer-reviewed studies looking at when a known child is in the school or a known staff member is in school with later confirmed to have COVID, rates of secondary transmission in school tend to be are quite low in these studies. Many of the studies actually, look at 200, 300, 400 close contacts at school and find 0 cases of transmission. Others find in the range of 0.5, 1.5 to 2%. So school-based transmission occurs, but at very low rates. And also most of these studies were done early on before a lot of the universal precautions that are now in effect, including mask wearing and other sorts of distancing requirements that we're certainly recommending as key guidelines. And then probably most reassuring if we think about the risk to adults in the schools, there have been now several reports looking at overall case rates of infection among teachers and staff in countries that didn't close schools. And in 2 of those reports that have looked at this issue, they find that the rates of infection for teachers and staff is either comparable or lower than the population average for the population. So further evidence to suggest that school-based transmission is lower than in many other settings. Dave, you can go to the next slide. There's a nice and relevant new report from the European Union CDC looking both at the overall evidence as well as some direct data collected from 15 countries, many of which had reopened schools. And their bottom line conclusions are, again, that school-based transmission is uncommon. And one of the ways I think this sentence is really important is they're pointing out that children who have infections when school's in session doesn't necessarily mean they got it at school. And when they do the detailed contact tracing, they're often seeing that these are household contacts or other community contacts. And that matches what we see in Massachusetts. The spike in children's cases in Massachusetts was in April. Schools were closed. Other sorts of contacts, similar conclusion for the adults. Let's go on to the next one, Dave. So caveats and context, new studies are always coming out, right? We are updating this at least once weekly from our own reading of the literature, from media reports, from social media, from questions and comments from parents, from teachers. Lower risk isn't 0 risk, and we keep emphasizing this in our discussion. Without safeguards, there can be outbreaks. In Georgia, in that camp, they had kids in poorly ventilated cabins for overnight stays without masks, and they had a widespread outbreak. So we have to be cautious. But we should also point out school closures don't mean 0 risk either. All you have to do is walk around Brookline and know that when you close schools, you don't prevent child-to-child interactions, you shift them to different settings. Right? You shift them to playgrounds, you shift them to ad hoc babysitting arrangements in people's houses as everyone tries to kind of figure out how to manage their lives. And so this doesn't prevent them. We also have to acknowledge the public health impact, not just the educational impact of school closures. Studies have documented increased rates of mental illness among children, raising higher rates of food insecurity, increasing rates of unreported child neglect, all in studies that have also found disparate impacts by income and race and ethnicity. Finally, we have to look at schools in the context of other decisions that communities are making. So Dave, if you go ahead. In the newspaper this morning, as I was preparing these slides, a new report indicating that indoor dining has been linked to 10% of new infections. And this is based on some data from at least 3 states. The New York Times profiled this story as well 2 or 3 days ago. So this is something that Massachusetts is allowing. It's also occurring in Brookline. We have to think about our priorities in terms of risk tolerance and not just hold a 0 risk tolerance, which isn't really feasible for schools when we're not doing that in other settings that are potentially higher risk and with less societal value. Finally, I will very briefly, because I'm out of time, just show you our panel voted unanimously this past Friday on some potential benchmarks for reopening, though this doesn't replace a holistic assessment of trends. And we received input from 5 national experts on pandemic response for this. We ultimately recommended that in-person indoor schooling could resume with all of the other safeguards we're working on in place, as long as at least 3 of these core criteria are met. First, less than a 5% positive test rate in Brookline over the prior 14 days. This is based on guidelines from the World Health Organization, as well as a proposal from the American Federation of Teachers. We also propose looking at the statewide number there. And then 14-day new daily case average in Brookline, less than 10 per 100,000, as well as statewide. This metric comes from the Harvard Global Health Institute. This balances local and state issues. It also balances positivity, how frequently you're testing, because you can't manipulate all 4 of these metrics just by not testing, right? If you don't test enough, you drive down case rates, but your positivity rate goes up. So this gives us a confidence that we're seeing the real trends. I'll stop there. We have a lot other to get to. Thanks so much.
Thanks, Ben, and I'll pick it up from here. So hi, everyone. Thank you so much for making the time to let us present. Again, my name is Dave Gayshak. I'm not one of the doctors or scientists on on our panel, but I have ended up with the portfolio of working with our outside expert consultants on enhanced clean air ventilation in indoor spaces as one among many of the protective measures that the public schools of Brookline are looking to employ in the context of a return to school, along with universal masking, along with minimum 6-foot distancing, increased attention to hand hygiene, et cetera, et cetera. So we have looked with help from the Harvard Chan School's Healthy Buildings team led by a PSB parent, Joe Allen, who is one of the leading experts in the country, perhaps the world, on healthy buildings issues, and has been looking for several years at healthy school buildings issues. He came in to present to us last month, and we can make materials from that presentation available to anyone who is interested in more detail, but we'll give you the quick version here. That being based upon the recommendations from his team, PSB is looking at using enhanced indoor air ventilation as, like I said, an additional protective measure or layer of defense, not a baseline health and safety requirement, because we're obviously using school buildings and other town buildings for various purposes this summer, like summer camps, et cetera, without necessarily having put all this in place first. But this is going to be one among many layers of additional anti-transmission protection that PSB is considering. Targeting with a goal, not a bright line, but a goal of at least 5 air changes per hour of clean air in all indoor spaces. Clean air being, for this purpose, based upon the Healthy Building Team's recommendation, a combination of fresh outdoor air being brought directly in, either through mechanical ventilation or through open windows, plus any recirculated air that counts towards that total being appropriately filtered at a MERV 13 level or higher, that we are advised by the Healthy Buildings team has been shown to significantly to trap most, if not all, virus particles in the air. And also deploying portable HEPA filtered air cleaners, similar to what many of us may have seen in dentists or doctors' offices if we've been there recently, as additional air cleaning to dilute and remove any potential airborne virus from the environment. These levels, it's a sliding scale shown on the right. Obviously, this is not a bright line where a little bit below 5 is insufficient and just above 5 is great. The higher we get, the better we get. And we're talking about levels that are approximately twice current building code levels. So just to give a quick illustration of how this plays out, and sorry we're moving so fast, but we'll come back in more detail wherever any Dr. Jed or any of Dr. Sloff or any of the other panel members would like. Here's how this plays out in a typical size classroom, where you've got a max occupancy already. These are approximations at 6-foot distancing. If you measure by building code, we would be providing in new construction or significant renovation construction, 2.5 to maybe 3 or thereabout air changes per hour. Looking at what the Massachusetts Teachers Association has recommended as an alternative standard, which is 20 cubic feet per minute, we'd be providing, per occupant, excuse me, we'd be providing, between 2.5 and 3, again, air changes per hour. PSB is targeting these higher levels of 4 or 5 air changes per hour as an additional protective measure above and beyond what its baseline requirements are. And with that, turn the next overview section over to Dr. Pollack.
Okay, so I'm going to talk about testing and how it relates to our school reopening plans. Next slide. So why test school kids and staff for COVID-19? I think we all know this, but just to set the frame for this conversation. So reasons include, we want to identify people who have COVID-19 so that we can rapidly isolate them and quarantine them to avoid transmission. But we also want to exclude COVID in a symptomatic individual so that they can return to school and work. And I will be pointing out that this issue has a major potential impact on the teaching workforce. We also want to know how many cases are out there to guide our decisions about modifications to procedures and closing classrooms and so on. But the take-home message is that testing will have the highest impact if results can be generated and used quickly. Next slide. So here are some arguments for a centralized COVID testing strategy for Brookline. So we would argue that access to expedited COVID testing for all symptomatic school children and staff as our first priority will allow for real-time assessment of risk and facilitate rapid response to reduce transmission and keep our schools open. Unfortunately, many Brookline school kids and staff don't currently have access to rapid turnaround time testing for COVID, which we would define as less than or equal to 24 hours. And this is because testing in Massachusetts relies on a network of independent testing centers that have very different capacities. Some of them do not test children or are not comfortable with it. And they have, importantly, a very wide range of results turnaround time, anywhere from an acceptable less than 24 hours to an unacceptable 7 days. Next slide. So for background, and we can come back to this later, but just to review, we're talking about molecular testing as our reference method. When we say turnaround time or TAT, we mean sample collection, transport testing, and results return. Those all factor into turnaround time. And then sample type, nasopharyngeal or NP floc swab is still what's preferred by the FDA, but anterior nasal or AN swab is an accepted alternative and is starting to become what people want to do. The CDC doesn't have a preference. And the keys with anterior nasal swab are that they can be collected, self-collected by an adult, and easily collected by a clinician, which makes access much more broad. Okay, next. Okay, so I just wanted to go over the status quo of how testing works now. So if we do nothing, what will happen is that each individual who is symptomatic will get tested, or a case contact will get tested in the symptom of their choice. So just to walk through this, and I won't belabor it, but just to walk through the timing. So let's say a school kid or a staff member in Brookline has symptoms consistent with COVID. They're going to call their primary care physician, PCP, or their local testing site and get scheduled. Maybe that'll take a day. They'll get there, they'll get a sample. And then here's the problem. Testing results returning to the Mass DPH and the local health department through Maven, also to the ordering provider. That can take up to 1 to 7 days, okay? So once those results are in Maven, then for Brookline residents that have positive results, the health department, as Dr. Jett knows well, initiates contact tracing, and that includes notification of school nurses and the person themselves. But if it's not a Brookline resident, then their local health department manages their positive result, and that can take a varied amount of time. The provider is going to return the results to the individual. That can take up to a day, let's say. And then the individual can choose to notify the health department and the school, which can take another 1 to 2 days. And I want to remind everyone that the Brookline Health Department is following results for Brookline residents and is focused on positive results. Next slide. So to finish the pathway, I just want to point out that our Brookline Health Department has done a tremendous job in facilitating contact tracing, and the school notification process would already appear to be fast. However, other jurisdictions have their own processes, and not all teachers and families have PCPs. So we could give everyone a list of walk-in testing centers, but the same time constraints I just described are going to apply. And importantly, any positive results for teachers or students who live outside of Brookline, and we have many, will go to their hometown Department of Health. So negative results also for returning to school decisions would have to be reported to the school nurse by the individuals themselves. So the take home here is that the time from symptoms to actionable results that would be available to school could be anywhere from 2 to, and totally unacceptable, 11 days. So obvious delays in notification, quarantine, and decision-making about how to get back to school. Next. So we wanted to lay out this question. So this is something we have discussed a lot on Advisory Panel 4, and I know is also on your mind. So is an expedited COVID-19 testing program actually essential for Brookline schools to reopen? So I just made the case for it being important. Is it essential for us to reopen schools? And we would argue, and this is the gist of the statement that we put out publicly, that from a pure health and safety perspective, we think the answer is no, it is not essential. And why is that? It's because symptomatic kids and staff are supposed to stay home until they have been tested. And my next slide will demonstrate some of the issues with that. But we think that, and we are confident that in-school safety strategies, masks, distancing, hygiene, ventilation, that's going to reduce the risk of transmission from those who are left in school, the asymptomatic individuals. And we want to point out that other Brookline settings, camps and dining and so on, as we discussed, they've opened without rapid turnaround testing programs in place. And schools elsewhere are also opening without these kinds of programs in place. So we summarize that rapid turnaround testing would definitely be a very useful tool, but without it, we don't think that a school return is unsafe. However, the flip side, ongoing operational perspective, once we're open, we think that an expedited testing program is absolutely essential because, as I'll show you, until and unless COVID negative status is confirmed in a symptomatic individual, they're isolated, they are out for up to 14 days from the onset of symptoms. And as you all know, Many of the symptoms that are consistent with COVID are also consistent with other diseases, flu, colds, so fevers, coughs, and so on. So this means a lot of people are going to be out for a long time, potentially unnecessarily. And particularly during cold and flu season, these are going to add up, cascading isolation periods. And this is going to be a major, major operational challenge to stay open once we're open. Of course, if we do have any cases, despite all of our measures, rapid turnaround testing would obviously expedite contact tracing and testing efforts. So those are the reasons to say yes. But here is an excerpt from the DESI guidelines from July 17th. And what you see highlighted here is what happens when an individual is symptomatic. Okay, and I'm going to make the case that testing delays are going to severely impact our in-person school workforce and disrupt learning. So you can see that if an individual is symptomatic in yellow, they have to stay home and get tested. If they're at school when they get symptomatic, they go home and they get tested. And now you see in the third column that once you test negative, you are, per DESI guidelines, allowed to return to school once you're asymptomatic for 24 hours. But imagine if your test takes 7 days to return, okay? Similarly, if you don't get tested at all, you are out for a full 14 days. So this is why these isolation periods will stack up for symptomatic kids and staff who likely, almost certainly, based on our rates, have something other than COVID. Okay, next. Okay, so then serial testing, a word about this. So what serial testing is for asymptomatic individuals, and there are pros and cons to this. The goal of this is obviously to try to capture new asymptomatic cases. And the sort of agreed upon frequency would be weekly, because if you test less frequently than this, you could miss new infections and spread. But the volume when you start doing this is very large. And importantly, insurance will likely not cover asymptomatic screening testing after the first initial test, perhaps. And pooling is something that we can discuss, but it is not yet widely available and not available around here, and potentially will be coming soon. The key is that testing all students and staff serially will be very expensive. We could consider testing staff only serially, especially to reduce anxiety, especially to reassure. But we still would be, it would be important to avoid a false sense of security. Everyone would have to still maintain infection control and all the measures we're talking about. And you could argue that funds spent on serial testing could be spent in other ways, on other infection control measures. The thing is that healthcare workers, while they are not being serially tested like this, a lot of people are, universities, employees, and so this is becoming more and more sort of popular, and there's a lot of discussion about this. Next. So this has led us to try to develop a centralized testing program as part of a consortium called the Safer Teachers, Safer Students Consortium. This is meant to be a collaboration between 5 districts, Wellesley, Revere, Chelsea, Somerville, and Brookline, with the goal to create a feasibility pathway so that other districts across the state can follow suit. And ideally, this would ultimately be funded by the state and be available to everybody. But basically, it's a proposal to use a shared operations partner to coordinate centralized testing sites within each of these 5 districts, all using the same infrastructure. We would use anterior nasal swabs. We would partner with an operations partner like MassCon and One Medical. We would send tests to the Broad laboratory. That's our first sort of plan. We have multiple backup plans in place. First priority, symptomatic students and staff for the reasons I outlined. Second priority, weekly serial testing of student-facing staff for the reasons I outlined. And the whole purpose is that results would come back quickly, both to the patient and to our district Department of Health, and that they would get to the school nurse as quickly as possible to allow decision-making. We'd like to bill insurance. We want to have a way to route non-resident teacher and student results to our own district Department of Health. There's a lot of discussion about how to raise funds. There's discussion with the town, but we have the support of the school committee and our superintendent, and now we are hoping to gather leadership from the select board, town meeting, and our own Department of Health to allow us to participate in this consortium. And I'll note that there are already more than 15 other districts who have contacted the leaders of this consortium to ask to participate. So finally, to summarize, so we would argue that access to diagnostic testing with rapid turnaround time is a key component of a multi-pronged strategy to allow as many children and staff to attend school in person as much as possible. By doing this, we can monitor our community, we can react quickly, we can maintain the amazing response that we have had in Brookline to date. And expedited testing will avoid workforce and learning disruptions. But as I said, our panel board does not think that this rapid testing program is an absolute public health and safety prerequisite to return to school. And as I said, we think there are measures in place to prevent in-school transmission that will be effective, Symptomatic kids and staff should not be in school in the first place. And we also wanted to point out that there are programs that are open without this. There's testing capacity in Massachusetts that we can access if we act quickly. We think Brookline is well situated to coordinate this, to successfully do this and provide access to testing for the school community and perhaps the whole town. We'd like to bill testing to insurance payers and limit the cost to our town, but we want to remind everybody that if we don't have an effective plan for doing this in schools, our teachers may be less willing to return to the classroom. So I will stop there. Happy to answer any questions, and I'm sure the others are as well.
It would be nice maybe to stop sharing so we can all see each other. Is that all right? So I certainly have a few questions, but I want to see if other members of the council do as well.
Can I make a comment or a question, Tony?
Sure, go ahead.
So this is Peter Moyer. I love the idea of a shared operations department or whatever it was termed. I think we desperately need it to pool our resources, and we have to stop saying we don't have the testing. We got to get the testing. So I'm very excited by that idea. That's my editorial comment.
So I mean, we're going to have to talk about, because I've heard questions about whether we're going to have to go ahead with what we have and not what we would wish we have. And
Yeah,
whether,
I don't know how soon that would be operational. I'm just saying.
How feasible it is. But I do want to challenge and get your response to the notion of the testing not being essential for safety. Because the place where I think it could fall apart is around contact tracing. Because kids are going to be infectious or asymptomatic, they'll have been in a classroom for several days, perhaps infectious. So even if they don't come to school when they're sick, they could have already spread it to other kids who are asymptomatic. And so we could have 3 or 4 generations of transmission. If we don't, within the day or two of that first index case having gone home, know that it's COVID, we're not going to know that we have to close that classroom down. So I guess my scenario is that we might have multiple classrooms already infected and spreading infection into days 7, 8, 9. You know, the one kid who is sick at that point is quarantined at home. But it's only if that kid is tested immediately upon showing symptoms that we would know that a classroom has to either be contact tracing, testing, because we're not going to be doing contact tracing of every kid who's symptomatic. We're only going to be doing contact tracing of every kid who's tested. So again, that's where I'm worried about not testing.
Yeah, I mean, it's a good point. I mean, Ben can comment on the context and the fact that there hasn't been a lot of in-school transmission, but in the studies that he presented. But this is all sort of a balance of resources, and if we had all the resources in the world, both dollars and test kits, then we would do more. But we feel as a group that that the safety measures that are in place, the expected low levels of transmission from asymptomatic kids in the school context based on the literature, and that the safety measures should be effective, and that what we are offering for symptomatic kids would be, I guess this is a very difficult needle to thread, right? As you're pointing out. If it were up to me and resources were infinite, we would just do this tomorrow and have it in place. We are arguing that it is not essential to opening our schools in the first place. Okay. Ben,
Ben, do you want to go ahead?
Yeah, I was just gonna say, I mean, I think this is where both the case rates in the community being where they are, which is quite low, and the overall transmission rates in the evidence are really critical, because we're talking about, with the 6-foot distancing guidelines that your committee recommended, that Dr. Marini's embraced, that our panel, I believe, is voting on, and will almost certainly embrace as well, that we're talking about evidence from studies of transmission rates in schools of less than 2%, in some cases less than 1%, and that's before universal masking. That's before ventilatory upgrades that we're imposing. That's before 6-foot distancing. So if you're in cohorts of 10, we're not really talking about that those 1 or 2 days that some students might have been there pre-symptomatically able to transmit. We're not talking about waves and waves of outbreaks, and that's not what's happened in all of the countries in the world that have opened. I mean, the cases that we've read about that are most concerning in school transmission are out of Israel. And if you look in the fine print, what happened there essentially was they had a big outbreak in a junior and a high school during a heat wave when they closed all the windows, then they stopped, they waived the mask requirement, and they had class sizes of 30 to 40. So as in Georgia, our argument is very clearly that the evidence shows you can get COVID and you can transmit it. You have to take these precautions, but with the multiple layers of precautions, the transmission rates in schools are quite low and well below what other community settings that we're allowing people to dine without testing them before they go into the restaurant. We're allowing servers to serve in restaurants without being tested. We're allowing kids to spend time in indoor classrooms in these very same buildings in summer camp without this testing. All of that's going on now. So I think we just have to have a similar level of kind of risk mitigation or at least risk tolerance to make sure that we get the benefits from school. That would be, I think, our committee's general gestalt of how this fits in the bigger picture.
Right. I mean, I'll point out there are people like Redliner at Columbia and Ostrom from the University of Minnesota are saying, we actually should go all the way back to a complete shutdown right now to get this out. And so I guess that's the flip side of the coin of the point you've made. Yeah, the other challenge I want to put out to you, just because you did an extraordinary amount of work and it was really great to look at that data. I mean, and I had not heard about Israel and that they waived masks right before that outbreak. Having not gotten the level of expertise that you've been able to delve into, though, I find myself worrying a lot about confirmation bias. And you as you presented, you are parents first, and there's lots of pressure on all of you to get your kids back. So, and I know, as somebody who, the safest thing for me to do is to advise Dr. Jett to keep the schools closed, because that sort of protects my, the role that I have to do. And so I'm just pointing out, there's so many unknowns, even around some of the data that you've presented, that I just, and as a society, we keep doing this. We cherry pick what we want to believe, and then we pursue it, and it's gotten egg on our face. So again, that's my concern in listening to you. And I just, if you have a response, I know nobody can fully defend themselves from that challenge, but your thoughts on it would be helpful to me.
If we were the first jurisdiction to talk about reopening schools, I'd have a lot more uncertainty and a lot more concern that, well, we have all this data, but does it really apply when schools are open? And that's where all of the real world data from millions of children in other countries that have opened with, in many cases, incidents similar to Massachusetts, in some countries slightly higher than where we are, in other countries slightly lower, as well as in some places that never closed. So I completely agree with you. I think there's a big risk here of latching on to results that are confirming where we are. I think that's one of the really important things about the evidence review, is that we are drawing on like dozens and dozens of studies, not like picking one study and saying, look, there's high levels of RNA in the nose of young children. That on its own doesn't really tell us much about school-based transmission. We really are trying to draw on a broad body of literature. And I guess the other point I'd come back to is, if the current status quo in Brookline was that we were still on a full shutdown because that's our level of risk tolerance for COVID, it would be a lot more understandable to say we can't afford to take the chance of opening schools. But why schools would be held to a standard that is much more restrictive than other things that evidence suggests are higher risk activities for both the people doing it and for the community as a whole, that doesn't seem to be something I can reconcile easily with also the relative advantages of reopening, because there are huge downsides of staying closed. It's not just parents wanting their kids in school, it's what the kids themselves experience and the broader community impact. So I'll stop there, but I hear your point. I also think we have a whole lot more data on this, and that we're not holding the same standards for everything else that's happening around the state and in Brookline right now.
I guess I want to add to that by saying the fact that we're parents makes it even more important to us that our kids are safe at school. We're talking about sending our own kids to school. And I am going to make decisions about sending them to school based on the science. And that's what we're trying to do here. We are particularly concerned about sending our own kids to school. So the fact that we are saying we would be comfortable with it I think goes against any idea of confirmation bias looking in the other direction.
Other members of the committee, do you have questions? Well, I guess, Pat.
Thank you for this. It's really, you've done so much work and it's very, very helpful. And my question is different. A lot of our schools are older. My kids went to Lawrence and to the high school as well. And I'm just wondering, because I know very little about air exchange, how feasible it is that we really will achieve even 2 to 3 air exchanges in an hour in some of these classrooms, and also how it will be measured and monitored over time. And how important it is in the whole, variety of other things that we can do.
And on that same question, I'm just curious about timeline for kind of the assessment and implementation of that plan.
And I believe that Matt Gillis from the school's operations team is actually in the attendees for this call. And so if folks want real detail, certainly can turn it over to him. But let me take the first swing on behalf of panel 4. Based upon the advice that we've gotten from the Harvard Healthy Buildings team, I want to stress first, these enhanced air quality targets and higher levels of air changes per hour are not, as I said, the baseline, don't enter because it's not safe if we don't get there. These are an additional layer of protection that we are recommending be put in place to further suppress transmission risk. In terms of how we get there, what we've been advised is we're in one place at least, we are basically there already. Our new building at Ridley and Coolidge Corner already provides, subject to verification, which is going to happen between now and the beginning of school, but expects to provide, and it's brand new, 4 air changes an hour of a combination of either completely fresh outdoor air or MERV 14 filtered recirculated air in all spaces. So that's a building that's already there. There's another category of buildings that have existing HVAC systems that PSB and town facilities staff think can accommodate MERV 13 or higher filtering, even though the systems are not spec'd for that. That's being tested right now. Those include Runkle, for example, where we may be able to retrofit existing HVAC systems without, we're talking about turning up motors and changing filters, not rebuilding things. And so those are steps that are being measured and then tried and implemented if they work over the next 2 to 3 to 4 weeks, not a matter of months. And then the backstop of all this is, as we've, probably the easiest, and it's easy for me to say because I'm not the one who's actually doing the procurement, but the easiest, most straightforward way to do all of this is through portable HEPA filtered air cleaning. We can either with 1 unit per classroom and other occupied space that is sized appropriately to the volume of the space and the number of occupants, or if we can't find that, through putting 2 units or even 3 units in a space where needed. We can bring those air changes per hour of clean air up basically as high as our tolerance for spending money on buying buying portable HEPA filtered cleaners allows, because if we have 2.0 air changes per hour of fresh air in a given space, which is where facilities estimates that most of our older school buildings sit right now. If we put a cleaner that provides volume equivalent to an extra 3.0 air changes per hour in that room, and we change the filters according to manufacturer recommendations, that right there brings us up to the high target without any changes to the HVAC system. So the procurement is a challenge here. Obviously, lots of people are seeking these same units right now, but the latest I have heard from the folks who are actually implementing this at PSB is that we have 100 in hand already, and we have several hundred more on order with expected delivery over the coming couple of weeks for at least a major tranche of it. So it is very feasible that we will have the capacity to bring a number of additional classrooms, like multiple hundred additional classrooms online within that time frame from the reports that we've gotten from the operations staff.
So Dr. Jett, I don't know if you're in a position to comment on this. I know when I mentioned the consortium to you, you had said that you'd already been told that from a financial perspective, it was a non-starter for the town. You know, again, I'm wondering what you can say about this at this point, because obviously, again, we want to, whatever advice we give, we want it to be about with what we can actually do, not what we wish we could do.
Yeah. So first, you know, I want to say great presentation. You have gathered a lot of data. And so I want to align because a lot of questions circle about how to engage the ACPH and how to engage myself in the health department. So you are officially a subcommittee, how I view, of the school committee, a task force. And it would be as if the select will come up with a task force. So my position is, you know, I work directly for the town administrator and the select board appointed, and the ACPH is appointed, and they advise me on public health issues. In our collaboration, always in the past, my direction, and I think it's written into a lot of bylaws, et cetera, is I advise the school superintendent. If issues arise, then, you know, I come before the school committee and I advise the school committee issues. I usually stay out of the processes that the school committee sets up. And I do that by right because, you know, that's their ball of court. The only time I get involved on anything town related is usually on the select board side, because that's my direct chain of command and who I report to. And so I try to stay out of that process as much as possible into the decision making. One of the things that I have done, and with advice from the advisory council, is we sent a letter to you, which is our recommendations. And that's sort of, you know, recommendations that we made that we thought is very feasible in reopening schools. I sent it to the superintendent as well, and I also advised the town. Because we think the best method, if you do bring kids back, is to do it outdoors and then stay a hybrid remote, at least until it becomes cold. And hopefully by that time, that would allow enough information to come out about ionization and ways that we can kill pathogens in buildings. I know the statement was made before about, you know, restaurants open. Usually restaurants, what I have noticed in my inspections and visiting, is that people are only there for an hour. What I'm concerned about is people in a classroom for longer than 3 or 4 hours. I'm concerned, just like what I'm noticing by the numerous complaints I receive, about people maintaining masks and wearing masks, because I know that that's just not feasible. We bring them beat back. You know, I have kids in that age range. They don't wear their mask all the time. I'm just gonna be honest. There is nothing I can do to force a kid to wear a mask all day. It won't happen. Even though there is low transmissions in schools, there have been instances where a child did pass it to a teacher and the teacher died. So when I think about risk and I think about risk assessment, you know, from an epidemiologist standpoint, you know, I'm always looking to reduce mortality, not reduce mobility. Mortality is first. And I usually ground my decisions, you know, based on that. Some of these decisions I have made during COVID has been far ahead of the state at times. And I think part of that had saved us because I had taken some hard stances. One of the first steps I took, you know, I'm thinking I looked at the death report, is there is no way in the world that I'm going to change the science, the etiology of COVID to say, now I'm going to put somebody within 3 feet. And then I'm going to test somebody, you know, person that's symptomatic, I send everybody home that's asymptomatic, and I'm going to test them immediately. And that's the problem when I think about etiology of the disease. If it's a 14-day quarantine, there is a reason, the science behind why that's in place. And it was because of numerous amount of cases, you know, the symptoms could have showed up at the 10th day, the 11th day, the 13th, or the 14th day. I've had cases where, yeah, we did close the schools. The whole idea when we closed the schools was everybody stay home, and we closed essential, non-essential business. Now, what should have happened, which didn't, is that we tested everybody at that point. We cut off travel. I have been quarantining people in Brookline since January. We could have easily cut off travel from abroad, stop the disease in its tracks, closed down for 30, 45 days, tested everybody. We didn't. So my numbers suggesting now, which is still, mind you, underreported, is that COVID is still in the midst because we messed up along the way. We allowed people, asymptomatic said, you know, they didn't need to wear masks. Then all of a sudden we said they spread. And so, you know, I have a little bit of flexibility, very little flexibility in changing what I think will keep Brookline safe. And, you know, that's the spill I would give. You know, me and ACPH have talked, the same spill I've given to the select board. You know, I want to be able to sleep at night. And so, you know, that's kind of like where I stand.
Go ahead, Ben.
I completely appreciate everything that you just said, Dr. Jen. And I think we all have similar priorities. I think that the question, one of the questions that our committee has come back to is just in thinking about how do we deal with a world where there is no zero risk environment. And I think all of us have the fear that someone in the schools dies is a nightmare. It's a terrible situation. We know that 24 restaurant workers in New York City have died since the beginning of the epidemic. We know that, I don't know what the comparable numbers are for Massachusetts, but we have in-person dining here. We know that we've had kids in public school buildings in Brookline for summer education programs approved by Brookline Public Health. And that's before any of the ventilation upgrades and some of the other requirements we're talking about. And we've also had data on over 1,000 kids in Brookline who've attended camp programs, some of which are indoors, and have actually had no outbreaks in camps. So the risks are there, but I guess we're struggling with, it seems like the schools are being asked to carry a far higher standard of risk avoidance that we're not calling for in any other aspect of what's happening in the state. And when the downsides of those kids going without schooling is so much larger than if we were to say, we're not going to let people eat in restaurants, we're not going to let people exercise in gyms or go to casinos. So that's the disconnect in the relative risk trade-offs that I think our panel is really struggling with and trying to come up with those safeguards to make schools as low risk as possible.
Yeah, I understand that struggle. Here's what I don't struggle with. Me dying versus my child. I'm gonna always safeguard my children more so than myself. And so I'm not confused about that. If we put kids to the high standard, and I think we have to protect them. Here's another thing that you have to consider. And, when you think about camps, you are correct. Counselors have no problem. The age of the counselor is in their 20s. The age of your school teacher, average age is what? So you're not thinking just about, at least my aspect, just about the kid. You also have to consider the age of the teachers in the school. And I'm sure this has been very perplexed for the teachers as well, because I know they're scared. I would be. I would be.
Can I also get back the notion of having this consortium idea? You said the town has said that that's not feasible. Is that correct?
So none of the other health departments, because usually what would happen is the other health departments would reach out and they would say, let's collaborate on this. I haven't received feedback from anybody. We are starting to dive into it. I think cost is going to be the ultimate factor, because you're still looking at somebody has to pick up the tab. Unlike other states, the state health department did a lot of the work, and they set up testing sites. Right now, the state is setting up testing sites primarily for areas where they have outbreaks. And so they have 17 sites around the states right now, which is the highest focus. And you know, so, you know, one of the other crux of Brookline is that, you know, we only have 2 testing sites, Physician One and Partners. If you look at Boston, they have 33. And so, you know, they have a lot more places where people can get testing quickly. I've always been curious how many people in Brookline cannot get a test. I've even tried to open up a site where I could send people that don't have insurance. Even the 2 entities that are open, you know, have trouble responding and setting it up. Even when I've tried to set up, like I did with the antibody testing, an opportunity to work with another entity to do the testing for us, because, you know, we don't have the manpower. In a normal scenario, and by previous health departments, I had clinical operations where we could do it for the school. And there would be a place where people would go and get tested just like we do vaccinations. But, you know, people want to ensure that for the staff and the time and the cost of the test, people will get reimbursed. And the cost of the testing now ranges from 60 to 100 just to run the sample. And, you know, which is odd, but it seems like now the longer we into this race, the more costly testing is becoming. So.
All right, so Neera, I'm going to let you speak, and I'm going to just double check whether any of our committee have other questions, because we're way over time, and it's a critical issue. We need to spend it, but I want to make sure that we have time as a committee to discuss. So please, Neera, go ahead.
Sure, I was just going to say, I totally agree with you that we are very under-resourced in terms of testing sites in Brookline. There isn't anywhere straightforward for most people to go, which is another argument for a centralized testing site. And in fact, it would be great if it could benefit the whole town. Part of the idea of joining this consortium is that then you can, through numbers, reduce costs. And the idea is to get tests done at cost from the road, which may be on the order of $25 per test. And then the operations infrastructure adds more funds, but in total, it would be somewhere around between $60 and $70 a test for the whole thing, for the whole process, including collection. And ideally, all those symptomatic people, almost all of them could be reimbursed by billing insurance. So that is all part of the goal. We can certainly have, you know, outreach, particularly from the Wellesley Board of Health, which is the most engaged so far. The Wellesley team is the farthest along in all of their planning. So if that would be helpful, we could connect those dots. But this has sort of been, you know, emerging organically from parents to school committees to boards of health to select boards and so on, and through all of these districts and through all these other districts now in Massachusetts. So.
Dr. Jett, what does the state say? How do they respond? Because obviously testing is key to this. It would make it so much easier and safer to open schools. What does the state say in terms of the various towns? Does Baker talk about it?
You know, so the only thing that, you know, I've really heard from the Board of Health calls and the state calls is, you know, they want us to be involved in the school reopening, but not necessarily approving the plans. You know, they and what they were looking at, not necessarily Brookline, but they were looking at some, you know, the public health infrastructure in some towns and cities is very limited. And so they didn't want to drain that resource. But so let me back up. I've been trying to do some type of community testing when I thought it was feasible. And if we had like an outbreak or something, like not just a nursing home, but a senior living facility or Brookline housing. So I reached out to the state a while ago to get, you know, the swabs from them, but I still need somebody, you know, to do the solutions. And so if an outbreak does happen in Brookline housing, you know, that's going to be the first place I hit. So I'm setting on 5,000 swabs now in preparation for that, and do mass testing. So, you know, that's what the state has committed to. Now, I would tell you the state shut down their lab because that was the other place that I was going to work with. But they shut down the lab for COVID in order to focus in on West Nile virus and Triple E. And, you know, as you know, that I can't explain. I saw the look, Tony. I can't explain it. But yeah, I didn't understand that one. In the middle of the worst pandemic that I have been alive for, and we worried about West Nile virus and Triple E. So it's just a different model. And I think, you know, Dr. Monica Burrell's doing the best she can, you know, based on the priorities. So.
All right. Are there any other questions for our guests? Gretchen?
Yeah, I just have a couple of questions. One, I was interested if you've gotten much feedback or pushback from teachers on kind of these plans moving forward. Obviously, there's a lot of concern and fear in that space, but just curious their response. And then also kind of with the timeline question I was alluding to earlier, I think September 16th is when they're hoping to have in person for BEEP and kindergarten and vulnerable students. So I'm just wondering in that timeline, what might be achievable, or where, if we're saying like, okay, actually these areas are great for, you know, they're kind of meeting what we're hoping, the levels we're hoping to meet, will you be then putting in-person classes in specific areas based on that result? And if there's also then any response to kind of having our young and then the most vulnerable students kind of the first ones to test this out, and how anyone has felt about that. Or even if we know the numbers of how many might be interested in person. Sorry, that's like 10 questions altogether, but maybe there's some response to those questions.
We could try to share. I think many of them are probably better answered by Dr. Marini and the staff team and the school committee, because we have the benefit of doing the public health and safety related school specific work and advising them. But the thousands of emails are more heavily directed towards them than us. So for that, I think there is some things we can cite. You know, there certainly is a very robust public conversation involving parents, teachers, others, with you know, views being expressed, you know, coming from many different directions. I think that there were several you know, parents who expressed varying views at the school committee meetings over the past week or two. There were many teachers who spoke who expressed varying levels of concern. Things that we're doing, the Massachusetts Teachers Association has put out its own list of recommendations for what the parameters around a safe return to school would look like, and we're trying to help the district be responsive to those in terms of evaluating them, making recommendations from our panel, pointing out places where we have questions or don't think that something is you know, makes sense from our perspective as a key place for resources. We are working right now with the Brookline Educators Union to put together a educator-specific Q&A session and forum where members of the BEU will have the chance to interact directly with some of, unlike me, the real experts who are here, you know, from our panel who can answer questions about in that context. About their health and safety concerns about coming back to school. So that's another measure that's going on. And then in terms of timeline, I mean, what the superintendent has announced is that the return from a primarily remote, what they're calling remote plus plan, up to more in-person education in whatever form that takes is as of today's announcement, largely driven by making sure that classrooms meet the enhanced ventilation targets that we've discussed. There are obviously also significant operational challenges to work out in there too. And we're talking about different spacing and occupancy densities than we're used to, staffing issues, et cetera. And so those are all being worked out that we're not part of, but the sense is that from the communications to the parent community from the superintendent's office, that there is a plan moving forward to, as rooms become hitting the enhanced targets, that the plan is to use them. So I hope that it answered at least some of them, Dr. Stoddard, and certainly can get PSB to provide more specific answers to the ones that we could.
Yeah, if I can just chime in very quickly, I think that one of the most difficult parts, as I said since the beginning, is really to communicate the fact that there are multiple preventive measures that are needed. So you may have some teachers that are focusing on ventilation only, and that seems to be the only solution to all the problems, right? So I think that part of our job has been communicating and try to educate and answer some questions directed to us in terms of the complexity of the multiple measures that can be put in place. And going back also to the school closure and the safety of the teachers, I totally understand, Dr. Jett, what you mean. It's a huge responsibility. The reality is also, though, that there are equity concerns. So when we close the schools and the kids are home, they're going to be left with grandparents, especially for families that cannot afford to have childcare. So when I think about the consequences of the school closure, I really, that's what concerns me the most, and that's what we are also trying to address with this panel.
David, did you have a question?
Yeah, I just had a question, probably mostly to Ben, which is what's the data? Are there any good data about the differences between opening grade schools versus high schools?
Yeah, so Israel, which is kind of the location of the biggest school-based outbreak, the central cluster was at a high school. That's an N of 1, but that's suggestive. The teens are certainly physiologically likely to be closer to adults. There's mixed evidence. There was a really widely cited study the New York Times wrote up that showed that kids under 10 were about half the risk of transmission, whereas 10 to 20 was similar or even slightly higher than adults. There's been a subsequent, also peer-reviewed publication on the same data, basically finding the opposite, unfortunately. So for our hands up, basically the key issue seems to be, how do you treat the index case? Because a lot of times what happens is a kid and a parent develop an infection within a day of each other. And it's hard to know who actually brought it in or whether they both got it from someone else. And so at best, what I would say is right now is there's some evidence that has potentially been contradicted, but it's that older teens are more likely to transmit. Given all the inherent uncertainties around this, it seems reasonable, and this kind of answers Dr. Stoddard's question, if you were going to start with an age group where the risk of transmission is probably lower and the benefits of in-person school are probably bigger, you would think it's younger children. High school and college students, can they do remote learning? Probably more effectively than 5-year-olds. And if the risk of transmission, while not definitively higher in high school, at least plausibly higher, that would also kind of lead you to the same conclusion that it makes sense to phase in. And that's what almost all of the guidelines from WHO, from the Harvard Global Health Institute, from the state indicate that when you're at the thresholds to get people back in, you prioritize the younger age groups, I think, for those reasons.
Okay, so now I'm going to ask you guys, again, this is open government and we're an formal advisory council, so you are welcome to listen, but we're going to ask you to stay back and let us talk among ourselves. And you're welcome to phase out your video so you can multitask or focus in. I guess what I want to start with is just think a little bit about, what is the scope of the advice that we can give you, Dr. Jett, right? Because I think you're being called on to give an opinion as to the school's plan or not. If I understand correctly, the big sticking point between at least the preliminary plan, the early opening with a limited number of students is the indoor versus outdoor, right? Because we're on the same page around the 6 feet, I'm not sure actually for sure whether you've, whether part of your opinion is whether you're okay with the selected number of students coming back at all. But so tell us what scope of advice to you is going to be, useful to you, but also pertinent to the decision you're going to have to make in the next days and weeks.
Well, I think the advice that you gave me, I want to say last week or the week before last, and the memo that was drafted, that's sort of where I'm at. And the same advice, I would give, and I have given to Dr. Marini now, almost a month ago. I truly believe the best course of action to take is to have class outside. And they have class outside, 7,000 students, half students outside, and then they swap and do remote. And that would allow enough time for them to figure out the air exchange, but also the ionization, some way to kill pathogens in school. It's not just, I'm more leaning toward a way to kill pathogens rather than to move air around. Specifically talking about how old the school buildings are. When you get to 3 to 5 air exchanges, it's going to be fairly expensive to do the ongoing testing. It's going to be expensive no matter how we cut it. The only thing that we can do, to me, is reduce the transmission. And to me, the effective way to do that is, wear a mask and be outside, and do it half a day and not a full day.
Right. So being outside is going to be realistic until somewhere
October, November.
Well, probably mid-October. I don't think.
Yeah.
Heat goes on about October 15th, right? So that.
But climate change.
Maybe you might gain an hour. But I don't think you gain a week. Pat.
Just on that point, the outdoor versus indoor, and maybe somebody who's followed the literature knows this, but I did see a district where they structured the school day so that kids were in school for 45 minutes and then outside for 15 minutes in every hour, which goes along with your comment, Dr. Jett, about people in restaurants only for an hour. So it was good for the kids just to get out, and also, it was sort of a natural way to do some of the air exchange. And I don't know if anybody knows of that trial.
I know that this is what they have been doing during the summer in Italy for the Conservatory of Music, because they have been teaching during the whole summer. So they will do 40, 45 minutes and then 20 minutes to sanitize the place and air exchange, and then back into class.
I mean, just as a compromise, and it could work in the winter as well.
Yes.
So, in some ways, I'm less thinking about compromise and thinking about, what we really want to clearly state is what we think is the safest way to proceed. I mean, will the school committee go ahead, with or without our recommendation? Again, I'm not sure exactly what power you either have or want to wield in the face of what the school committee decides that there might be differently. We can certainly make it clear that again, because I'm personally, a lot of what was presented today is very persuasive to me, although again, like you, Dr. Jett, I worry very much about, kids are not going to keep masks on. 6 feet of distance sitting at the desk does not mean 6 feet of distance when the bell rings and all 15 kids hit the doorway at once. They go to the bathroom, they'll take their, so I do think we could say that, look, until the air ventilation is fully in place with or without ionization, outdoors is safer. We could say that we do believe that a testing plan that is funded so that there can be results within one day for any symptomatic child or staff will make a difference with safety. You know, rather than talking about absolutes. And so we would strongly urge those things. So that doesn't change anything we've already said. I don't think it changes anything that you've recommended at this point.
No, and I think the school committee has already decided and voted
To go with
to
their,
do.
and again, the only big sticking point difference is the indoor versus outdoor.
Right.
Okay. And then the other issue again is, you know, what is your wording about testing? Is it, you know, absolutely necessary? Is it better? You know,
it is absolutely necessary. It would be better if we just had more testing in Brookline, and not just for the school system.
Right.
You know, I look at, you know, all the citizens, and you know, I would like to see more testing sites to capture that. And I know that our numbers would increase,
Yeah.
but at least I will have a better idea if we start to see trends. Right now, we solely relying upon private sector in order to, you know, funnel our data. And I think, you know, it should be done the opposite direction.
I think we should add that as part of our comment. I do. I think we should. And I like the comment. It's an emotional comment, but it's true. But I said, what are we doing not opening schools if we are opening bars, indoor restaurants, casinos? I think there's a strong argument in that direction.
I agree. That's hard to justify, to say like,
But
we're fine with restaurants. But no
I think the
schools.
rest of the towns are all suffering this as well. I think we really should push for consortiums and for whatever was suggested, you know, $70, $60 price instead of $125, and get the governor's got to face this. He should really come through with some aid and coming up with a solution. Money
Well,
wise,
you know, if they want to push the schools to open, just like the federal government and the president wants the schools to open, then probably Sunday they got to test.
That's what I would say. I say our biggest, you know, our biggest fear is disease spreads out. We're unable to test for it, and you know,
because that's been an issue. Yeah, that's been an issue all along. We have never tested everybody.
We got a long ways to go with this epidemic. I think we should solve that problem.
Yeah. So, you know, I kind of like being in the position of not stopping a train that we couldn't stop even if we wanted to.
Yeah.
You know, I do think that, you know, the point that was made about the kid staying home and then giving it to the grandmother instead of the teacher is a real one. As is the fact, you know, that what we know is that the upper middle class parents are going to go into pods with, you know, unlicensed teachers who may or may not themselves be tested or safe or at risk in their own homes. We're going to have kids who are totally unsupervised during the day. So, you know, part of me wants to not open the schools to keep kids safe, but part of me understands that there's no way to keep kids safe. And you know, as I said, there's zero risk. But we should have the opportunity to say that the safest way to open the schools is with universally available testing, anyone who's symptomatic with a result back in one day, and whether it's the state or the town or a consortium that funds it, it should be part of this opening plan. Now, it's not going to stop the schools from opening without it, and I think we're making a point that's, you know, it's not going to happen day one, but to the extent that we can push it to happen sooner, you know, and particularly if there are any mini outbreaks in September or October, saying that now might make it more likely that there'll be more resources put into testing earlier. That's sort of where I see things.
And just having done contact tracing here in the town, I think to really make a point of saying there's testing and then there's testing where you get the results in less than 24 hours. Because even with the best intentions with the testing availability we have now, it's really not always effective. It really needs to be less than 24-hour turnaround to, you know, to make a difference.
Yeah, you know what? You know, the key to it, which a lot of people don't want to do, is if you're symptomatic, you know, you stay home and you get a test, you wait for the test result, but everybody that has exposure, they stay at home as well.
Right.
And I think the problem is, it don't make a difference how long it takes to get the test back. If you're at home waiting to get a result, that's where you need to be and stop the spread.
Right. Well, that's why the rapidity is so critically important, right? Because lots of kids are going to get sniffles, right? So by October, I would imagine 2/3 of the classrooms are going to have a kid with sniffles, right? If the rule is that that kid stays home, right? But also every kid who's in contact with that kid also stays home until they either spend 14 days or are tested, we will functionally shut the schools down in October completely, unless either we do the one-day testing or we say to hell with it, we're not going to require kids with sniffles who maybe only have a 20% chance of having COVID are treated as if they're possible cases. And that would be a disaster. Right?
So one thing to add, and it's not, mainly the sniffles. I have seen a large absentee in the schools nationwide during flu season.
Yeah.
So, one of the things too is other countries have noticed that have already dealt with the flu season, wearing a mask actually reduced the amount of flu and the spread of flu.
Right.
So, one of the things to look at, the risk, if they are wearing masks, then, we could do a different risk exposure based on that. The problem is if they are not wearing a mask all the time.
Right.
So we will be relying upon the teacher to provide that information.
Right. It might not be a bad public health measure in this year to require flu shots for admission to school.
Yeah. Well, we have gotten extra flu vaccine in preparation, but, again, we planned a lot of flu clinics, so I anticipate a lot more people.
Yeah, I mean, the flu vaccine's available in CVS now.
Yeah.
I mean, again, we could debate the making it mandatory, but we sure should be pushing flu very heavily, right? Because if we can, we don't know how effective that vaccine is going to be, but if we can cut the flu rate in half, we'll significantly drop the number of people who are going to have to be quarantined because we suspect they have COVID.
Correct.
So that's an important thing to be done. Other thoughts and other things that you need from us. So what is the school committee or the superintendent asking of you right now? Is there something specific you're being asked to comment on?
No, not at this point. We provided the feedback to them.
Yeah.
And, it's up to them to take it up, or if they want us to come forth or they want me to speak to them, it's up to them, because I did ask Dr. Marini if he wanted me to speak to the school committee. He could definitely bring me along before the vote. But, that didn't occur at this point. So, the ball is in their hands. The ball is in my hands when the outbreak occurs. That's the time that that I address the school committee.
The other thing that I think is going to happen is, particularly if we are, smart and lucky and careful, and we get to mid-October without any significant upticks, there's going to be a significant push to get every kid into at least some class learning. So I suspect we're going to be asked to speak to that.
Well, I mentioned it to this panel 4 that one of the lessons we can learn is see what happens in the South, because they start school earlier than we are, and they have a 3-week head start.
Right. Although they, again, have much higher levels in the community than we do. So we certainly have an advantage there. So I know it doesn't seem like there's anything that we are doing as an advisory council that you're doing now as commissioner that contradicts the advice of the guests who we had presenting to us earlier. I mean, I think the staying outdoors again, since the school committee is treating that as elective, I still like our saying that because I do think with the unknowns, it makes things safer and it still allows school to happen and happen in real time. So unless there's anybody who feels like we should step back from that, there's nothing else that we have recommended that stops the school committee's plan from going forward. I guess the other question is there some way for us to empower you to make something happen on testing?
No, not at this time. I will wait to see what happens with the consortium. I have to connect to see what they're at and how much the health department is involved in that. I think the bottom line that's going to happen, we'll see the feasibility of it, and the testing and the cost, and then centrally located, because I'm sure when you have different school systems, everybody send their kids in to test. I could see that surge capacity real quick as well. So no, I think you have given me enough advice as to what direction to take, and I appreciate it.
All right. Is there a possibility of adding some sort of heightened get your flu shot, get it early this year?
Definitely. Sure.
Yeah, we definitely would do that.
For both reasons, not just to make the disease worse, but also to make the confusion in the diagnosis less.
Right. And it would be good for flu too, even if we didn't have.
That's what I'm saying, yeah.
All right. Anything else? Any other questions, concerns, suggestions?
It was a good group.
Yeah, I was just going to say I really appreciate hearing from everyone on panel 4. I think they're all still here. So just thank you so much for putting together a presentation for us. Thank you for your work. Obviously, this is really challenging time for everyone. And I am so appreciative for the work that you're doing for Brookline, for our community, and for sharing with us. As you mentioned in the beginning, communication is important. So this was really helpful. So thanks for being here with us too.
I second that. Thank you so much.
Yeah, thank you. And everybody have a good night.
Thank you.
Thanks for
Thank
having
you
us.
for having us.
Let's do. I don't think anything bad is going to happen to the health of Brookline if we look at the minutes at our next meeting.
I agree.
Is that all right with everybody?
Yep.
We'll leave.
Okay. So,
Bye.
all right, with that, I think we will adjourn. Thank you.